Hello, everyone. My name is Ying Tan. I'm a clinical molecular geneticist and a founding director of the Molecular Genetic Laboratory in New York City Office of Chief Medical Examiner for over 20 years. First of all, I would like to thank RTI and Forensic Technology Center of Excellence for hosting the educational events. The focus of my presentation is on post-mortem genetic testing panels and sampling strategies. My talk is one of the 5 presentations on molecular autopsy implementation in the New York City Office of Chief Medical Examiner. The other presentations are from the perspectives of a chief medical examiner, a senior medical examiner, a clinician, and a genetic counselor. This is the part 1 of my presentation. In this presentation, I would like to introduce the current postmortem genetic testing menu in our office and a workflow from sample collection, test request, testing procedures, and data analysis process to reporting and genetic counseling. In part 2 of my presentation, I would like to illustrate the utility of postmortem genetic testing using our publication or unpublished case examples. I would also like to highlight how NIJ grants supported our work. Finally, I would like to discuss about future directions. Current postmortem genetic testing menu in our office. Each year, approximately 6,000 cases are autopsied in our office. The breakdown of the cases autopsied by manner of death showed 47% natural death, 25% accidental death, 10% homicide, 7% suicide, 7% therapeutic complication death, and 3% undetermined death. Majority of the cases requested for molecular genetic testing are from the natural death category, and some are undetermined death. Each year, approximately 600 cases are sent to molecular genetic laboratory. The cases fall under 3 categories. First, there are positive pathology findings, such as cardiomyopathy, thoracic aortic dissection and rupture, seizure disorders, or pulmonary embolism. In those cases, we look for monogenic explanations or increased genetic risk. Second, negative autopsy and the cause of death is unexplained. In those cases, we look for cardiac channelopathy for cardiac arrhythmia syndrome, neuronal channelopathy for seizure disorder, or renal channelopathy. And the third, samples are held for future testing. There are 2 reasons why postmortem genetic testing is needed. First, the testing results may provide a genetic explanation to cause of death. And second, the testing results may benefit at-risk family members through effective clinical care. This table shows the current postmortem genetic testing menu in our office. It contains a panel A, which is a cardiac-focused panel, where we analyze 132 genes associated with cardiac arrhythmia syndromes and cardiomyopathy. This panel also includes non-cardiac channel genes. A panel B is an epilepsy-focused panel, where 159 genes associated with epileptic disorders are analyzed. Panel C is a combined analysis of cardiac and epilepsy genes. On aortopathy panel, 20 genes associated with thoracic aortic aneurysm, dissection, and ruptures are analyzed. On our malignant hyperthermia susceptibility panel, we analyze 3 genes associated with this condition. On thrombophilia panel, we analyze 3 anticoagulant genes, in addition to factor V Leiden and factor II single nucleotide polymorphism. On sickle cell disease analysis panel, we detect beta hemoglobin S and C alleles. Our laboratory has been accredited by CAP since 2011. In the next few slides, I will explain each panel in detail. It is important to point out that for the diseases we test for on our sudden death panels, there are effective clinical management for family members who carry the same pathogenic variants. For deaths due to chronic diseases with ante-mortem clinical diagnosis or treatment options are limited for family members, we do not test them. Examples include neurodegenerative disorders, cancer, and familial hypercholesterolemia. Our testing menu was created following the international expert group consensus and guideline according to the 2020 Asian Pacific Heart Rhythm Society and Heart Rhythm Society practice recommendation for phenotype known cases. Phenotype-driven gene analysis indicated. For phenotype unknown cases, arrhythmia gene analysis is indicated. Hypothesis-free genetic testing using whole genome sequencing or exome sequencing is not recommended by this guideline. When there are cardiac pathology phenotype of hypertrophic cardiomyopathy, dilated cardiomyopathy, or arrhythmogenic cardiomyopathy, cardiac hypertrophy, fibrosis, or myocarditis, analyzing sarcomere genes, protein kinase genes, or desmosome genes in panel A are indicated. When there are thoracic aortic aneurysm, dissection, and rupture, or internal soft organ rupture, analyzing genes for syndromic connective tissue disorders such as Marfan syndrome, Loeys-Diaz syndrome, and vascular Ehlers-Danlos syndrome, or genes associated with non-syndromic connective tissue disorder on our aortopathy gene panel is indicated. When there are pulmonary embolism due to DVT in young individual without strong external factors, such as surgery that damages epithelial cells of blood vessel, or bed resting or long flight that cause stasis of blood flow, analyzing genes associated with thrombophilia on our panel is indicated. On our panel, we test antithrombin 3 gene, Pro-S and Pro-C genes, in addition to factor V Leiden and prothrombin polymorphism. When autopsy showed death due to seizures, we analyzed genes known to be associated with dominant inheritance of epileptic disorders. Genes we analyze can be characterized into 4 groups. Ion channel genes, such as sodium, potassium, GABA receptor, as well as NMDA receptors. Second group is genes involved in synaptic activities. Third group is genes products involved in mTOR pathways. And the fourth group is gene products involved in chromatin remodeling or transcription regulations. Genes not on our epileptic-focused panel include diseases on newborn screening panel, usually is autosomal recessive disorder, mitochondrial DNA mutations, epigenetic disorders or imprinting disorder, such as Angelman syndrome. We also would not be able to accurately report large-scale DNA rearrangements or chromosomal abnormalities. And finally, new epileptic disease genes will not be analyzed. When there's a history of an individual undergoing a surgical procedure and experienced muscle rigidity, breakdown of muscle fibers, high fever, acidosis, and a rapid heart rate, analyzing 3 genes on our malignant hyperthermia susceptibility panel is indicated. When there are pathology finding of sickled red blood cells or history However, the ME could not find the record of a past testing result. Analyzing hemoglobin S and C alleles are indicated. Please note that hemoglobinopathy are on a state newborn screening panel where you can obtain testing results from. For autopsy-negative cases, we'll analyze genes associated with diseases that can cause fatal cardiac arrhythmia. One is autosomal dominant form of cardiac channelopathy, a collective group of conduction system disorder with distinct ECG features such as long QT, short QT, or Brugada syndrome, or CPVT. In a postmortem setting, since ECG cannot be done, we can analyze the gene known to be associated with those conditions and make the diagnosis directly at the molecular level. Other diseases indirectly cause fatal cardiac arrhythmia, include epilepsy. In this situation, we analyze neuronal channel genes on our panel B. Additionally, kidney disorders such as autosomal recessive Bartter syndrome and Gitman syndrome can cause fatal cardiac arrhythmia, and the renal channel genes are on our panel A to be analyzed. In summary, autopsy-negative cases is where we analyze combined panel A and panel B. The workflow of postmortem genetic testing in our office starts from a case suspicious of underlying genetic etiology. The ME submit test request and a collected sample to the laboratory. And in the laboratory, testing, data analysis, variant interpretation, and generate lab reports and send back the lab report to the medical examiner. The medical examiner then disclose the cause of death alongside the genetic testing finding to the family and refer them to speak to our genetic counselor. In the next few slides, I will walk you through each step of this workflow. In our office, a blood stain card is saved for all cases. It is easy to make by the medical examiner. When it is dried, the cards are stored at room temperature, and the DNA on dried blood stain card is stable. We also recommend to save a tissue sample, such as a piece of heart, in our later for undecomposed cases. This tissue type gives abundant DNA and also allows tissue-specific RNA studies when needed. In decomp cases, we recommend to collect soft bone marrows, prefer red marrow if possible, in aerator tubes. Aerator is a liquid, non-toxic tissue storage reagent that rapidly penetrates into the tissue and stabilize and protect the RNA and the DNA in unfrozen specimens. Tissues in aerator is stable at room temperature for 1 week. Short-term storage is 4-degree refrigeration, and a long-term storage requires -20 or -80 degree freezers. By using aerator and minimize the need to immediately process the frozen tissue in liquid nitrogen. Formalin-fixed, paraffin-embedded samples are not a reliable source for postmortem genetic testing. We published our work on testing FFPE samples on Forensic Science International in 2020. Our data showed low quality of FFPE samples in comparison to unrelated tissues from the same case. We also showed sequencing artifacts due to formalin fixation in comparison to unrelated tissue from the same case. Without the unrelated tissue, for comparison, a sequence variant would not be known to be a true variant or it's an artifact, making molecular diagnosis unreliable. The sample submission and the test order form need to be filled out for each case. The top of our requisition form requires information of the case with tool identifier, and the bottom of the form, we collect test order and its indication. Collected samples and the test request form are brought to our laboratory through evidence unit following strict chain of custody rules. Once samples and the test order are received in the laboratory, testing will begin. The testing methodology is massive parallel sequencing based. Testing is aided by large automated liquid handler. We use Agilent SureSelect kit for DNA fragmentation and a library preparation, and the Illumina's NextSeq 500 instrument for sequencing. For low coverage region or low confidence variant confirmation, we also do Sangang sequencing. The entire pre-analytical, analytical, and post-analytical process follows CAP requirements. Sequencing data analysis goes through several highly automated steps. We use commercially available software from SoftGenetic because they meet the CAP requirements. In primary analysis, sequencing reads quality filtering and alignment is performed. In secondary data analysis, variant quality filtering and annotation is performed. In a tertiary data analysis, variant interpretation is actually done by manually by me and reviewed by a PhD level geneticist and our genetic counselor. However, the software manage and maintain the interpretation. Sangang sequencing data analysis, we also use SoftGenetics software. It's called Mutation Surveyor for alignment and annotation. We interpret sequence variants followed American College of Medical Genetics and Association for Molecular Pathology guidelines. The evidence-based variant interpretation process involves first, we search for ClinGen and Omin to understand the role of a gene in diseases. We then search the variant in clinical databases and literature to know whether the variant was reported or published. We search population database to estimate minor allele frequency. We also do multiple in silico predictions for missense variants to understand their functional effects. And finally, we correlate the history and autopsy findings with the variant. And each variant is classified into one of the 5 categories: pathogenic variant, likely pathogenic variant, variant of uncertain significance, benign or likely benign variant. Each case, there are over 400 likely benign or benign variants, 0 to 5 variants of uncertain significance, and 0 to 2 pathogenic or likely pathogenic variant. The genetic testing report is usually one of the 3 types. First, a pathogenic or likely pathogenic variant detected. The variant is diagnostic and may explain the phenotype and the cause of death. Rarely, the finding is a secondary finding, which may not explain the cause of death, but is important for the family. Genetic counseling is highly recommended and familial testing is warranted. The second type, where a variant of uncertain significance is detected. The variant is not diagnostic and may or may not have contributed to the cause of death. Genetic counseling is recommended. Familial testing may be warranted. And the third type is no reportable variants. It is a negative report. Cause of death due to changes of genes being tested are reduced. However, it cannot rule out genetic etiology for cause of death. And potential expanded genetic tests, such as whole genome sequencing, may be warranted. This is the end of the Part 1 presentation. Part 2, I will discuss about OCME's publication and the case examples. And I also would like to highlight how NIJ grants supported molecular autopsy implementation in our office. And finally, we'll talk about what would be the future directions. This is the part 2 of my presentation on molecular panels and sampling strategies. In part 1, I introduced the current postmortem genetic testing menu in our office and explained the workflow from sample collection to reporting and genetic counseling. In part 2 of my presentation, I would like to illustrate the utility of postmortem genetic testing using our published and unpublished case examples. I would also like to highlight how NIJ grants supported our work and discuss future directions. Selected case examples and publications. In the next session, the case examples are from the cardiac-focused sudden death molecular analysis Panel A testing. The first case report was published in the journal Haley Young in 2018. The decedent was an 18-year-old Asian female college student who was found dead in her bedroom with trench coat and underwear on. Scene investigation, gross and microscopic examinations were negative. Microbiological test, toxicological test, and the vitreous humor chemistry analysis results were all negative. The cardiac-focused molecular testing panel was ordered. The cardiac gene analysis results showed a novel, likely pathogenic nonsense variant was detected in the casein H2 gene. Pathogenic variants in casein H2 gene cause dominant form of long QT syndrome, type 2, and short QT syndrome. Additionally, a variant of uncertain significance was found in the cACNA2D1 gene. A gene has also been implicated in cardiac arrhythmia syndrome. Family studies conducted at the Langone NYU Health Center showed that none of the parents and the 4 siblings had the casein H2 variant. So this variant arose de novo. Furthermore, the variant of uncertain significance was detected in the mother and 1 sister without any clinical phenotype, suggesting this variant is likely benign. What made this case unique is there were well-documented history that we don't always have for most cases. Her medical history showed that she had an abnormal prolonged QT interval on a recent ECG, and the stress test showed a high likelihood of having lung QT1 or lung QT2. Therefore, molecular testing finding correlated with medical history. With the knowledge of this variant arose de novo in the family, we were able to reclassify this variant from likely pathogenic variant to a pathogenic variant. So in summary, the cause of death of this 18-year-old college student was cardiac arrhythmia due to congenital long QT syndrome due to de novo pathogenic variant in the casein H2 gene. The family impact has no risk for the living parents and the living siblings who tested negative. Targeted variant screening for future pregnancy may be indicated due to germline mosaicism. The second case was an unpublished OCME case. The decedent was a 25-year-old African-American male who had no past medical history, found unresponsive inside the apartment by his mother. He was found supine on the bedroom floor in workout clothing with barbells beside him. maternal grandfather reported died of a heart attack in his 50s to 60s. The decedent had no prior health issue. There was no history of depression or suicide attempts. He did not smoke tobacco, use some social alcohol, not heavy, and possibly a small amount of marijuana. The mother and girlfriend denied decedent used any other drugs. He exercised regularly. Cardiac pathology examination showed marked fibrofatty replacement of right ventricle, remote myocardial infarct, biatrial cardiac dilation, and endocardial fibrosis. The pathological diagnosis was arrhythmogenic right ventricular cardiomyopathy. Cardiac gene analysis results showed a pathogenic frame shift variant detected in the PKP2 gene. A gene is known to be associated with arrhythmogenic cardiomyopathy. This variant has been reported in ClinVar and in several literature reports detected in unrelated individuals affected with ARVC. This is a good example showing that a genotype result explains the phenotype and cause of death. Cohort study from cardiac gene testing of 296 decedents was published in a Journal of Circulation, Genomic and Precision Medicine in 2017. We reported the diagnostic yields by ethnicity group and age group from birth to adults. Cardiac gene testing results from a large cohort is in preparation for peer-reviewed journal submissions. In this article, we reported our molecular testing yield in over 1,000 sudden death cases with diverse pathological findings and demographics. The pathogenic and likely pathogenic variants in genes associated with cardiomyopathy and cardiac arrhythmia syndromes were evaluated for their correlation with the phenotype and their role in cause of death. In consideration with other guidelines and recommendations, we proposed one targeted cardiac gene testing is valuable and one more extensive whole genome sequencing is warranted in a postmortem setting. Our study strongly supports a broader application of genetic testing in cases investigated by medical examiners and coroners in U.S., which would be advantageous to public health by preventing additional sudden deaths. In the next section, the case example was from the epilepsy-focused sudden death molecular analysis Panel B testing. In case 3, the decedent was a 9-year-old white girl who had a brief seizure at home the evening before her death. The mother stated her daughter had seizures since childhood, but eventually stopped. The seizures returned 2 years ago, and they never knew why she was having them. Neuropathology examination showed cellular changes consistent with history of seizure disorder and a recent seizure. Tissue sample was sent for molecular genetic testing of the epilepsy-focused panel. Epilepsy-focused testing panel showed the presence of a likely pathogenic variant in the SCN2A gene. SCN2A gene has been associated with a range of neurodevelopmental disorders, ranging from infantile onset epileptic encephalopathy to benign infantile seizures to autism spectrum disorder with intellectual disabilities. This case showed the correlation of genotyping results to the phenotype of seizure disorder and explained the cause of death. In the next section, the case examples are from the autopsy testing panel. In case 4, the decedent was a 24-year-old Hispanic man with a thoracic aortic dissection and no identifiable risk factor at the point of autopsy. The day before his death, he was evaluated for severe chest pain radiating to his throat. He went to the hospital and he was told he had gastritis and sent him home. Next day, he had witnessed a collapse in the presence of his wife from standing position. The decedent had no features of Marfan syndrome or Loeys-Dietz syndrome other than the thoracic aortic dissection. He had a normal appearance. He looked kind of storky rather than the classic lanky appearance. Normal fingers and hands. No noticeable increase in skin or tissue elasticity. No skeletal findings. And he had no hypertensive cardiovascular disease. His tox results was negative, and there was no known history of cocaine or any substance usage. No known family history of sudden death. A autopsy testing panel was ordered. The autopsy gene analysis results show the presence of a pathogenic nonsense variant in the FBN1 gene. Pathogenic variants in the FBN1 gene cause Marfan syndrome or non-syndromic aortic aneurysm and dissection. This variant had extensive literature reports and was found in both individuals affected by Marfan syndrome and sporadic non-syndromic aortic dissection. This example showed that the genotyping results correlated with the pathological findings and explains the underlying cause of death. Autopsy gene testing results from a cohort of 34 decedents who died of thoracic aortic dissection and rupture was published in the journal Cardiovascular Pathology this year in 2023. In this article, we reported the overall molecular testing yields of 23.5%. The yield was higher in 11 to 20 years old group and 21 to 30 years old group at 50% and 71% respectively. The genes with the greatest prevalence of pathogenic or likely pathogenic variant were FBN1 gene for Marfan syndrome, followed by TGFBR2 and TGFBR1 for Loeys-Dietz syndrome. In the next session, the examples are from the thrombophilia molecular analysis testing panel. In 2011, we published the testing results of factor V Leiden and factor II prothrombin G20-10A in cases of fatal pulmonary embolism in our office and reported ethnic differences in testing results and is particularly low in African American decedents. In 2017, we collaborated with Columbia University and conducted exome sequencing of in idiopathic fatal pulmonary embolism and reported the significant finding of 3 anticoagulate genes, SERPINC1, which is also antithrombin 3, PRO-S1, and PRO-C. In case 5 example, the decedent was a 48-year-old white male who had no past medical history other than seasonal allergies, who complained of shortness of breath for the past few days, then went into respiratory distress, wherewith wife moving things into new apartment. The wife is a nurse who had told the decedent to get checked for PE upon hearing the shortness of breath, as the decedent's aunt and father had a factor V Leiden variant. We tested the decedent for our thrombophilia molecular analysis panel, and the results showed that the decedent had a pathogenic variant in the SERPINC1 gene. SERPINC1 is also known as an antithrombin 3 gene. Pathogenic variants in SERPINC1 cause semi-dominant inherited antithrombin deficiency. This case example showed that the genotyping results correlated with the phenotype and explained the underlying cause of death. Next, I would like to acknowledge NIJ grant support in the implementation of post-mortem genetic testing in our office. Since 2011, we have received 4 NIJ grants under the category of research and development in forensic science for criminal justice purposes. The first grant, received in 2011, supported the development of massive parallel sequencing, also called next-generation sequencing testing and data analysis capacity that did not exist in a laboratory before, but providing a dedicated PhD-level research scientist, a benchtop sequencer, and reagents and supplies. This grant enabled a cardiac-focused testing panel to be developed. The second grant, received in 2014, supported the validation of the next-generation sequencing testing panel on various of post-mortem sample types, such as tissues in unrelated and blood stain card. Our pilot study on FFPE sample showed that this sample type is not a reliable source for accurate molecular diagnostic, was also supported by this grant. The third grant, received in 2015, supported functional and family studies of variants of uncertain significance, which resulted in approximately 10 PubMed-indexed publications. The grant also supported the recruitment of the first board-certified genetic counselor in our office. The fourth grant, received in 2018, supported testing of old unresolved cases and the copy number variant analysis pipeline. We have just completed this grant and are in the process of compiling these large data sets for publications. In summary, with NIJ strong commitment to research and development effort in forensic science, our office was able to develop and implement molecular autopsy in providing answers regarding cause of death to the medical examiners and inform effective sudden death prevention care to the families through clinical programs. Next, I would like to talk about future directions. The first new initiative we would like to take on is to help the families of the decedent whose genetic cause of death was identified through postmortem genetic testing. For the family member, through genetic counseling and informed consent, we would like to collect buccal swabs from the blood-related family members and test whether they also carry the same pathogenic variants and at a risk of developing the same condition. Testing positive family member will be referred to a New York City Health and Hospital Clinic, and tested negative family member will not require to have additional care related to the cause of the death of their loved ones. We call this new initiative program GIFTS for Genetic Intervention Family Testing Services. In order for this program to be implemented, our lab needs to obtain New York State Clinical Lab Evaluation Program permit. This service would reduce barriers to genetic testing and enable equal access. With streamlined coordination and early medical intervention, this would reduce sudden death in the family. The second initiative is to contribute to a broader implementation of molecular autopsy in the United States through fee-for-service model, which pending New York City approval or federal grants, we can help other medical examiners to extract DNA from their postmortem samples, such as blood stain cards, and testing using our office's validated testing panels, or send out to the external commercial laboratories for more expensive testing. We can also assist understanding of postmortem genetic testing results and assist in identifying local genetic program for the families outside New York State. As the leading medical examiner office in the United States, with over 20 years of molecular autopsy experience, we are willing and able to help. The acknowledgments go to three chief medical examiners, Dr. Charles Hirsch, Dr. Barbara Sampson, and Dr. Jason Graham, whose visions and strong leaderships are important for the continuous growth of molecular genetic laboratory in our office. Additionally, the acknowledgments go to past and current molecular genetic laboratory members. Without their scientific, technical knowledge, hard work, and dedication, the lab would not be in the current form. This is the end of part 2 presentation. Please send your comments or questions to my email address. Thank you for watching.